So welcome everyone and good afternoon. I'm Jean Witowski-Wendy and I'm Dean of the School of Public Health and Health Professions at the University of Buffalo. And I welcome you to the 5th Annual Richard V. Lee Lectureship in Global Health. We're delighted to have Dr. Ashish K. with us today to discuss COVID-19 pandemic and challenges in global health. First, I'd like to give you some background on Dr. Lee. Dr. Richard V. Lee was a former faculty member at the University of Buffalo, and the School of Public Health and Health Professions established this lectureship in Dr. Lee's honor in 2016. It's been supported by an endowment by one of his longtime close friends. Dr. Lee was a remarkable man with a career that spanned the world, and he made many contributions to multiple fields of study here in Western New York and across the globe. He was born in Islip, New York, and attended school in New Hampshire and Scotland. He received both his undergraduate and medical degrees from Yale University, and while in medical school, he was awarded the Ferris Prize in Anatomy and the Winternitz Pathology Prize. Dr. Lee did his residency and postdoctoral training at Yale New Haven, and after completing his residency, he worked for the Indian Health Service in Montana before returning to Yale as an assistant professor of clinical medicine. In 1976, Dr. Lee was recruited to the University of Buffalo, where he stayed for the remainder of his career. He served as the chief medical officer for the Buffalo Veterans Hospital and had faculty appointments in UB departments of medicine, obstetrics and gynecology, and pediatrics within the School of Medicine and Biomedical Science. He was also an adjunct professor in the Department of Epidemiology and Environmental Health in our school, and an adjunct professor of the Department of Anthropology in the College of Arts and Sciences. He was head of the Department of Medicine at Buffalo Women and Children's Hospital. In 2007, he received the C.C. Barnes Award from the International Society of Obstetric Medicine in recognition of his outstanding contributions to the field. He also served as medical director at Ecology and Environment and served as a medical consultant to both the Buffalo and Bronx zoos. In addition to his extensive clinical work, teaching and service at the University of Buffalo, global health and infectious diseases were of great interest to Dr. Lee. He found many opportunities for medical outreach work, primarily in Southeast Asia and China. He played an essential role in the university's international programs and outreach. The UB Office of International Education relied on his expertise as a medical consultant and a cultural liaison. As part of his international reach, Dr. Lee studied the health of isolated communities in remote areas, and he was a consultant to the World Health Organization. Dr. Lee was especially interested in infectious diseases he encountered in his work, such as tuberculosis and typhoid fever. In 2002, he wrote to the Journal of the Royal Society of Medicine regarding the achievements of mid-20th century immunization campaigns against infectious diseases like polio and measles. His emphasis on the importance of vaccines for preventing the spread of infectious diseases is perhaps even more timely today as public health officials, doctors, scientists across the world struggle to contain, treat, and prevent COVID-19. Dr. Lee served in editorial and review roles for many medical journals, including the Journal of the American Medical Association, American Journal of Medicine, Journal of Infectious Disease, Annals of Internal Medicine, Journal of Clinical Allergy and Immunology, Journal of Epidemiology, and the American Journal of Tropical Medicine and Hygiene. In addition to his involvement with many American professional organizations, he held memberships in the International Society of Travel Medicine, Royal Society of Medicine, Explorers Club, and the Royal Geographic Society. Dr. Lee had a major impact on our greater Western New York community and the world. Fundamentally, Dick was a teacher and humanitarian. He drew upon his inexhaustible resource of knowledge and wonderful stories to capture his students' interest. He had the ability to relate to anyone he met, regardless of culture, age, or station. He loved people and was devoted to helping them. He was a lifelong learner. Dr. Lee passed away in May of 2013. He is sorely missed by all of us at UB and the greater Western New York region. We are so pleased to honor him today with this lecture, and we're especially pleased that his wife, Susan Lee, and many who knew him well are able to join us for this celebration of his many achievements. I want to thank all the faculty, students, community partners, UB alumni, and guests to this event. It's my understanding that over 500 people are registered for this talk. Now let me introduce Dr. Lina Mew. She is an associate professor in the Department of Epidemiology and Environmental Health and the director of our school's Office of Global Health Initiatives. Dr. Mew has overseen the planning for this lecture and secured our speaker for today's talk. Thank you, Lina. Dr. Mew, will you please introduce and welcome our speaker?
Thank you, Jean, very much for bringing back this great memory with Dr. Lee. And good afternoon, everyone, and welcome to the 5th annual Richard Lee Lecture in Global Health. Before I introduce Dr. Jar, I would like to mention that following Dr. Jar's lecture, we'll have a time for the Q&A conversation led by our Dean, Dr. Redlining. If you have a question, please submit through the Q&A forum on the right side bottom of your screen. Today is really my great honor to introduce our guest speaker, Dr. Ashish K, who is a professor of health service policy and practice, the Dean of Brown University School of Public Health. Before he joined Brown University, Dr. Jha was a faculty member at Harvard Chan School of Public Health since 2004 and Harvard Medical School since 2005. He also served as a faculty director of Harvard Global Health Institute and Dean for the Global Strategy at Harvard Chan School of Public Health. Dr. Jha graduated from Columbia University with a BA in economics, received his MD from Harvard Medical School, and completed his Master of Public Health at Harvard Chan School of Public Health. He was elected to the National Academy of Medicine in 2013. Dr. Jha is recognized globally as an expert on pandemic preparedness and response, as well as the health policy research and practice. He has led groundbreaking research around Ebola and now on the front line of COVID-19 response, leading national and international analysis of key issues and advising state and federal policy maker. And he has extensively researched how to improve the quality and reduce the cost of healthcare, focusing on the impact of public health policy nationally and around the globe. Dr. Jha recently has been a very frequent contributor to a wide range of public media. Now, please all join me in welcoming our lead lecture speaker, Dr. Ashish K.
Thank you. Thank you very much for having me here. And it really is a special honor to be the Lee lecturer. Dr. Lee was a giant in global health. And also another personal connection I have is that I've spent most of my career practicing in the VA health system. And he was a very important member of the VA healthcare system in Buffalo and was recognized really nationally for his public health and clinical leadership. So it's an incredible honor to be the lead lecturer for today. And again, I want to thank the leadership of the University of Buffalo for inviting me and having me on. So I'm going to spend probably 25, 30 minutes because I feel like beyond that, it's always hard for people to keep focus on laying out where we are with this pandemic. So the topic of today is the COVID-19 pandemic and the impact on global health. And what I hope to cover over this 25, 30 minutes is to speak to you about where we are globally, where we are in the United States, what some models are for managing the pandemic. I also want to lay out a case for you that we are really entering an age of pandemics, and we have to, while we focus on getting through this current one, we have to think about the long-term perspective and how it is that we're going to get through pandemics that are surely to come in the years and decades ahead. I will also talk a little bit about the impact on our healthcare system in the US. And with all of this, I will try to bring both a global perspective and a national perspective and try to weave them together. And I'm sure I will miss certain critical points. And when I do, I hope that we can pick them up in the Q&A and cover them in whatever way you all think would be useful. So I'm going to keep the remarks a little bit shorter, not speak for the whole hour, but hope that there's plenty of time for a discussion that follows. So where are we with the global pandemic, the COVID-19 pandemic? So the COVID-19 pandemic, you may sometimes, for those of you who are students and others, sometimes it's confusing. Is it COVID-19? Is it SARS-CoV-2? And so some basic terminology. The virus is called SARS-CoV-2 because it's the second coronavirus. The first one that causes SARS, the first one was the one that caused the outbreak in 2003. So the virus is called SARS-CoV-2, and the disease it causes, we refer to as COVID-19, coronavirus disease identified initially in 2019. We are, I would argue, if you want to use a baseball analogy, and by the way, I grew up in Toronto, and so I grew up very close to Buffalo, watching Buffalo television stations, but I was a Blue Jays fan growing up. So for those of you who might be baseball fans, think of it as we are essentially at the bottom of the 5th inning of a 9-inning baseball game. Why do I say that? And by the way, when you think about bottom of the 5th inning, the good news is a lot of the game is behind us, but we still have a bunch of way to go, right? We still have a good 3 innings, actually 4 innings to go, right? 6th, 7th, 8th, and 9th. Okay, so why do I say that? I say that because I think of this as a primarily an 18-month pandemic. And I'm going to lay out, because by laying out my timeline, I think I'll hope that you'll understand both where we've been and where we are going. So 18-month pandemic. And by the way, it's always risky to put timelines around global pandemics because they go in ways that you can't predict. But I'm going to be bold and risky, and I'm going to tell you that this is an 18-month pandemic. Now let me explain it. The pandemic, in my mind, really begins around January 1st of this year. Now, those of you who know about this virus will say, whoa, 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 it started circulating in China before then, and the answer is it absolutely did. It probably started circulating in China sometime in September or October. I would say became quite widespread in probably many parts of China by late November, and by December it had probably left China in terms of infected people had left and had become global. My suspicion is that there were first cases probably in the United States sometime in December, but we don't know all of the details because we didn't know about the virus. But I'm still going to pick January 1 as the start date because it was on December 31st that China informed WHO that there was a new source of pneumonias, of viral pneumonia, of an unknown cause that was happening across Wuhan. And so December 31st is when WHO was informed. And on January 1, WHO formed an office to track down what was happening and how to deal with it. So if we mark that as the beginning of a global pandemic, January 1, I believe that the pandemic, it will not go away, but it will start getting under reasonable control, at least in the United States, by the end of June of 2021. It's an optimistic timeline, and I'll walk you through that timeline. But I think it is a reasonable one. And if that's right, then that gives you an 18-month window from January 1, 20 to June 30th, 21. We've just finished 10 months out of an 18-month time period. That's the bottom of the 5th inning. We're just rounding the end of the 5th inning. November 1st, a couple of days, we start the top of the 6th. Well, this is a game that we all hope does not go into extra innings. Right, so that's where we are. But it's important to mark timelines because one of the things that keeps happening is you keep hearing from people, this pandemic is going to be with us forever. And then you think, my God, is life going to be like this forever? Other people say we're rounding the corner and it's all going to be better in a couple of months. It's not going to be better in a couple of months. We're not going to be living like this forever. Life will get better. The pandemic will get under control. I promise you. And I suspect it'll be by like late spring to summer of next year that life will really start feeling better. So let me now give you a little bit of timeline of how this has all evolved, both in the US and globally. And then I'm going to talk about the future, and I'll tell you why I think next June, July is the time period to be looking forward to. Okay, the pandemic begins in China. And in January and February, it is mostly in East Asia and in Western Europe. Italy, Spain start seeing cases. It's really March, April, May that we see the epicenter of this disease start hitting the United States. During this time, we're also starting to see cases, a good number of cases in Brazil. We're starting to see cases in India, Russia. And whereas the US seems to get things under reasonably good control by the end of May, still a lot of cases happening. America opens up, and in June, July, and August sees a large surge, certainly June and July. Europe during this time, big surge starts in February, March, April. They shut down and really shut down and bring the virus levels to a very, very low level. And when they open up in June and July and much of August, things look really good. And Europeans get complacent and believe somehow that the pandemic is over. And that is the reason why we are where we are with Europe today. And I'll come to where we are today. And then keeping that global view, March, April, May in India, another major hotspot and a major nation in terms of people, is mostly locked down for a long period of time, keeps virus levels very, very low. But in May, as India opens up again, there really isn't a good plan for how to maintain the virus under control. And you see these big surges. We got to almost 100,000 cases a day in India just a couple of weeks ago. And then there are countries like Brazil, which have continued to have significant infections throughout the whole pandemic and is currently number 3 in the world in terms of infections and deaths. One of the places I have not mentioned very much is the African continent, which is interesting. So South Africa has had quite substantial outbreaks, but much of the African continent has done better. Some of the real leading standouts are places like Rwanda, which have had very strict travel controls. People can come to Rwanda, you can go, but you have to go quarantine for 2 weeks once you arrive. Very rigorously enforced mask mandates, reasonably good testing. And so Rwanda has done a pretty good job, really good job of managing this pandemic. There are other countries that have done a great job. South Korea, Taiwan, Singapore, Hong Kong, New Zealand, Germany, though Germany's having a flare now. But the bottom line is that there are countries that have managed their way through this pandemic without having to do very, very, very extreme lockdowns. And the way they've done it is a combination of mask wearing, testing and tracing, and social distancing. Things that are old school public health, the kinds of things that Dr. Lee would have recognized and recommended to all of us if he were with us today. Those are the kinds of things that the countries that have been successful have done. Countries that have been less successful, like ours, have largely ignored those or have done them unevenly. So our mask wearing is pretty uneven. We do some social distancing, but it's not always all that consistent. Our testing program is good, but it is not where it needs to be. And so when you do them not so well, you end up in a situation like our country where we have 9 million infections, 225,000 deaths, and things heading in the wrong direction. Thinking kind of a bit more globally, we are, again, right now at about 45 million people infected around the world. All of us think that's a substantial undercount, and there are probably hundreds of millions of people who've gotten infected. And the undercounts are driven primarily by the lack of testing. When countries don't have testing, people can get infected, can get sick, can die, and we don't notice it. But the official count is that over 1 million people across the world have died of this disease. All right. Let's take a look at kind of where we are today, what I expect will happen over the next 3 to 6 months. And then I want to get into some specific issues that I think are worth tackling. So where are we today? The United States right now is, all of us who have been on the front lines of this, believe that we are entering a very, very hard 6 to 12 weeks. So month and a half to 3 month time period. So that's November, December, January. We're just finishing October, are going to be very hard months for the United States. Why do I say that? Say that because we have 75, 80,000 cases a day being identified. The proportion of tests that are coming back positive is increasing, which means that we're missing more and more cases as days go on. And we're at a point where, because of both politicization of basic public health measures like wearing masks, and because of massive amounts of misinformation about the pandemic, how serious it is it just the flu? Is it a hoax? It has really made it hard for people to be focused on doing the things that they need to do to protect themselves and their families. And so I fully expect that we will be the first country in the world to have days where we have more than 100,000 cases in a single day. I don't believe any other country has achieved that. India came close, but never quite achieved it. I believe America will be the first country in the world to end up having days where they have 100,000 new infections. It's not just infections. What we're seeing in the United States now is hospitalizations are rising. Just over the last 2 weeks alone, number of people who are in the hospital with COVID has gone up 23%. And proportion of people who are dying, or I shouldn't say proportion, number of people dying has gone up also about 20%, just in the last couple of weeks. And given where we are with infections, I suspect those numbers are going to continue to climb. Some states are going to do better than others. And the state that you're all in, who knows where you're actually physically, but where Buffalo is, where New York State is one of the standouts. New York State is doing really well, relatively speaking, has a phenomenal testing program built, really led by Governor Cuomo. And the case numbers are still reasonably low. And if smart policy can dictate the approach, I believe New York can get through this time period without too much suffering. But it is going to be hard. But there are other states that are doing reasonably well. California is another state that is largely hanging in there, though they too are seeing meaningful increases in cases. Much of the country is not. And if you look at the upper Midwest, the Rocky Mountain states, the Dakotas, Montana, Wyoming, upper Midwest like Wisconsin, Nebraska, I'm not going to list them all. There are about 8 or 9 states that are in just a lot of trouble, just very, very high rates of infection, hospitals really quite full, deaths climbing, and little sense that things are going to turn around immediately. And of course, the rest of us, where I am in Massachusetts is where I live, Rhode Island is where I work, cases are going up quite substantially. And I think we're in for some very difficult days ahead. Why are we here? I've talked about some of this, politicization. I've talked about misinformation. Also colder air, colder weather. You all know this in Buffalo, certainly also true in Massachusetts, that it's hard to spend large amounts of time outdoors once the weather gets super cold. And social gatherings do move indoors. And the virus likes to spread more, or not likes to, the virus does spread more efficiently when the air is colder and the air is drier. And so I do believe that the winter will be a host for more efficient spread of this virus. So I said 6 to 12 weeks, and you may say, well, what's going to be better in 12 weeks? It'll be January. It's not going to be warmer in January. So why does life start looking better? And I think life starts looking better probably once January ends and we get into February, March, for a couple of reasons. Not because the weather will be warmer. I mean, again, having spent time in upstate New York and having spent time near Buffalo, late January, February is not a time where the weather is getting much better. So what does get better? And same in Massachusetts. So what does get better? I believe that we're going to have a lot more testing available. There's a lot of new improvements in testing technology, and that is going to become more ubiquitous across the country as this year comes to an end and the new year begins in January, February. Widespread testing will make an enormous difference in terms of keeping the virus under control. I also believe that in the next 4 to 6 weeks, we are likely to see the emergency use authorization of 1 or 2, or for lucky, maybe even 3 or 4 vaccines, probably 1 or 2. What that means is that we'll start being able to get people vaccinated. Now, in the first month or two, meaning December, January, I expect healthcare workers, first responders to get vaccinated. And in the weeks and months that follow, you'll start seeing high-risk people, some elderly people, essential workers get vaccinated. And then it'll be more like March, April, may even be like April, May, June, where large chunks of the rest of the American society gets vaccinated. And if by the end of June, I expect most Americans who want to get vaccinated will have gotten vaccinated. And if we're lucky, and if 60, 70% of Americans are willing to get vaccinated, and if we're lucky and the vaccine is 70 or 80% effective, it's not going to be 95% effective, not the first generation, then that will make an enormous difference in terms of how much protection there is in the community. And we are going to see the virus levels really come way, way down. And that's why I believe by the end of next June, while life will not be totally back to normal, things will really be meaningfully better once 60, 70% of Americans have gotten vaccinated. Obviously, this could go wrong, right? This could go wrong. We could get to a point where maybe people don't take the vaccine. Maybe we get to a point where the vaccine is not as effective as I'm hoping it will be. Those are possible, but I'm optimistic that by the end of next June, we will be there. And even by the end of January, February, if 10% of people, 15% of people have gotten vaccinated, plus if you think about how many people have already been infected, we may get to a point where we start seeing a slowing of the virus. And that's why I do think February, March will be better. April, May will be much better. And by June, July, we'll have some semblance of a new normal. That's in the US. I suspect a similar thing is going to happen in Europe. What about the rest of the world? When are the vaccines going to show up and what should we expect? Here, it largely depends on two or three things. One is how well the vaccine production and vaccine development goes. Second is our ability as a world to make billions of doses of the vaccine. So there are about 7 billion people in the world. Let's say we want to be able to get 4 or 5 billion people vaccinated. Many of these vaccines take 2 doses. That's like 10 billion doses. Making 10 billion doses of anything is incredibly complicated. Making 10 billion doses of vaccines that have to be managed incredibly well, high quality. Many of these vaccines need to be frozen at minus 96 degrees. And then we have to get it distributed. We have to make sure there are enough vials and syringes, and people have to get training. This is an enormous, enormous challenge. So even if we can develop a vaccine, getting it out into people will be very, very hard. And I think that is going to be a real challenge in front of us. But I think there is something called COVAX that you should all know about. And if you haven't heard about COVAX, I would look it up, COVAX. COVAX is a program put together by the World Health Organization, WHO, and by Gavi, which is a global alliance on vaccines. And Gavi and WHO, and then a bunch of member countries, have all committed to putting in resources and to making sure that vaccines are distributed around the world in an equitable way. So we don't end up in a situation where America has vaccine, European countries have vaccines, but the rest of the world does not. That I think would be incredibly bad from a moral and ethical point of view. It would also be politically very destabilizing. So COVAX is a global effort to get vaccines distributed around the world. Every country, every major country in the world has joined COVAX except one, and that's us. Our government has decided we don't want to participate in COVAX, and we're not going to play a helpful role for the rest of the world. I think that is really unfortunate. It's a total abdication of American leadership. America has always had great leadership in global health, not showing that great leadership right now. Depending on what happens next week with the election, if President Trump is reelected, I expect that nothing will change. If there is a President Biden, then I believe that America will join COVAX, and I think will play a helpful role in making sure that vaccines are distributed around the world. And realistically, I think the timeline for vaccinating people around the world, the billions of people, is probably gets beyond the spring, well into summer and fall of next year. And it might even be 2022 where large chunks of the world has gotten vaccinated. So we have a long way to go on this pandemic. And even though I believe that things will start getting better in February, March, and will be meaningfully better by April, May, June, for the rest of the world, that timeline is bigger than that, longer than that, and a lot of execution risk. And what I mean by that is these are all great plans that I've laid out of how it's all going to work. We got to get it done right, and it's very complicated. And there are a lot of logistical and supply chain issues that are going to hamper us. So that is where I think where that is happening. Let me say two more things maybe, and then I will finish and see where we can go on questions. One is I laid out in the very beginning, as we started this conversation, I said to all of you that we are entering an age of pandemics. That sounds a little scary, but I think it's true. So why do I say that? And so let me tell you why I say it and with a little bit of a story. So my first foray into really studying and thinking about pandemics and large-scale international disease outbreaks goes back to work that I did in 2014 with the Ebola outbreak in West Africa. And I co-led with a colleague and friend, Peter Piot at London School of Hygiene, a international panel that looked at the global response to Ebola. And as we did that work, it became very, very clear to me that a big global pandemic was likely coming. And in 2015, I put together a course when I was still at Harvard called Lessons from Ebola, Preventing the Next Pandemic. And in 2015, in that course, I pulled together leading experts from around the world. And I asked all of them, I had asked them lots of questions about Ebola and everything else. But then the last question I asked every expert, this was in 2015, and you can go watch the video. If you go to Harvard X, you can sign up and watch this whole course. But the question I asked every expert in 2015 was, if there is a global pandemic in 5 years, will the world be ready? The question was, if there's a global pandemic in 2020, will the world be ready? And everybody said, no, the world will not be ready. Now, you may say, am I telling you that I was some prescient future seer who could know that there was going to be a global pandemic in 2020? No. I picked 2020 kind of as a random year. But what I knew was what many of us have known. This is not something I knew individually. Many of us who've been studying this stuff knew, which was a global pandemic was coming. And every factor that led the world to be susceptible to a global pandemic is going to be with us for a long time. So let's talk about those factors. Why do I say we're entering the age of pandemics? Well, what causes pandemics? Pandemics usually happen when there's a relatively novel virus that starts in one place and then spreads globally. Why do I say novel virus? Because if it's not a novel virus, if it's a virus that's been circulating in humans for a long time, then it doesn't tend to, then there's a lot of built up immunity in the human population. One of the reasons why COVID-19 has been so bad, why this is a true pandemic, is none of us have immunity to this virus, right? So therefore, you need to look for a novel virus. So where do novel viruses come from? Well, there are billions of viruses in the world. The novel viruses that cause outbreaks in humans are almost always zoonotic in origin, meaning they almost always come from animals. So there might be some virus that's circulating in animals and doing fine, not bothering and then it makes a species jump to humans. That's what we think happened here. We think this was a bat virus that either directly or through an intermediary made a jump to humans. And why does that happen, or how does that happen? Well, it happens when humans come in greater contact with animals. This is why there's a whole field called One Health that tries to take an approach that thinks about both the animal and the human species and the interactions, and tries to think about a health from a much more holistic approach. And over time, more and more humans have been coming in contact with animals because of environmental changes, deforestation, climate change. Both of those have led people into other habitats that where humans have generally not gone before. Economic development in places like China and India means that meat consumption has gone up, and as meat consumption goes up, obviously humans tend to interact more with animals. And then, so that is why we're seeing more and more outbreaks. And we are seeing more outbreaks of novel diseases over the last 20 years. But that doesn't make it a pandemic. What makes it a pandemic is that when that local outbreak then spreads around the world and spreads around the world quickly. Why might that be happening? Globalization. So in 2015, if we were here and you had asked me, what did I think about the likelihood of a pandemic in the next 5 or 10 years? I would have said pretty high. And then if you had said, where would the pandemic come from? What would it look like? I would have said, so I was wrong about the influenza virus, it's a coronavirus, but not wrong about China. Why China? Is there something about China? Well, I'll tell you why China. China has had incredible economic development and has become a true global superpower, has become a very mobile nation. In 2003, when you had a SARS outbreak in China, China was a very different country. It was not nearly as global. There was not nearly as much internal or external travel. And that is what makes pandemics become, disease outbreaks become pandemics. And by the way, what is happening in China now is starting to happen in India, or I should say what has happened in China in the last decade is starting to happen in India, starting to happen across the African continent. So I don't necessarily believe that future pandemics will come from China. They could also come from India. They could come from Africa. They could come from the United States. We are a very global world. So we have to stop thinking about this in very nationalistic, like we can't build walls high enough to keep viruses out. We need to take a much more of a global approach. We are going to see a lot more disease outbreaks and pandemics over the next decade or two, and might even be sooner than that. So we have to prepare for that. All right, final point. I'm speaking to you as a public health professional, as a physician who studies public health, and obviously from a lectureship at a great public health school at University of Buffalo. This is a public health crisis that we're in. It's also not just a public health crisis, right? This has affected every aspect of our lives, from school and education to economics to everything. And as you, especially for those of you who are students, but really for all of us, we're always students. One of the key things to come out of this pandemic has to be of an understanding and a worldview that says public health is central, public health is very important, but if we're going to be effective, we've got to work with people outside of public health. We've got to work with political scientists. We've got to work with sociologists. We've got to work with education specialists. We've got to work with economists. Because what we do affects them and what they do affects us. And so I think it is absolutely critical in your education to try to find opportunities to learn other fields, but certainly after your education to find opportunities to connect and engage with experts in other areas. Obviously not just academics, but practitioners. This is such a major public health event that while the whole world now understands why public health is important, the world also isn't going to leave this big issue just to public health officials. And if we're going to be effective as public health practitioners and scholars, we're going to only be effective if we agree to broadly engage people outside of our area. All right, let me just say finally that I know this is a difficult time for everybody. And I know some of the things I've said may get you a little depressed about what I think is coming in the next 6 to 12 weeks. I do believe that we as a country and as a world will get through this. Pandemics do come to an end. This one will as well. And while we may be dealing with this virus in some form or another for a long time, lives will go back to some new version of normal. And that new version of normal can be even a better version than the old normal. It's largely up to us. And so I think if we all pull together, we take good care of each other and ourselves over the next couple of months, and as the pandemic and as the virus begins to recede in 2021, focus on science, wear your mask, get vaccinated when it's return. All of that can contribute to us getting to a much better place sooner rather than later. Thank you very much for having me. Again, it's an honor to give the Lee lecture. Dr. Lee really was a giant in various areas. He wasn't just in one, but he was a giant certainly in global public health. And it's an honor to be a part of anything associated with him. So thank you.
So thank you, Dr. Jha. It was just stimulating, fascinating. Again, as Lina said, your leadership in this area, I want to thank you for all of us, all the good work you do, and your clarity in explaining these issues to our students, and speaking to that we have to work across disciplines. The University of Buffalo is very interprofessional, interdecanal unit. We really support collaboration and working across units as a way to really advance the field. So I think our students and our faculty heard that. We had asked for questions as people registered, and we do have questions coming in the chat, but I'm going to start by asking you, and you've left ample time. I thank you for that, because I had a couple dozen questions before you even started your talk. So we'll see how far we can get through these. And I'm going to start with one that you kind of alluded to. It's an opinion on the likelihood of effective medical treatments for COVID. You talked a little bit about timing of vaccine, but could you speak a bit about treatments available in the next 12 months? And then getting back to the area of vaccine, you indicated by spring we should have vaccine. And the question to be added to that, do you think a vaccine is going to give long-term immunity, or will we be doing vaccination every 6 or 12 months when these vaccines do occur? And so if you could start there, and then a follow-up from one of our students on the chat talks about reducing barriers to getting vaccine. There seems to be a lot of concern and question. Some surveys suggest that less than half of people are intending to get vaccines. So you've got 3 parts in there, and I can go back and reread them if you lose it.
Oh, that's great. Okay, yeah, three related, slightly different issues, and 3 really important ones. So here's what I'm going to cover. I'm going to talk about therapies, where we are now, where we are likely to be in the next 3 to 6 months, and where I hope we might be in 12 months. And 12 months is hard to speculate on, but I'll try. And then second, we'll talk about vaccines, what their likely duration is, and how we deal with issues of vaccine skepticism and other barriers to vaccinations. So let's start with therapies. And I didn't really spend too much time talking about therapies. So I'm glad to have this opportunity. And one of the reasons I try to speak less up front is there are, I could go longer, but there are important issues that you're all thinking about. And I want to have the chance to address that as opposed to what I think is interesting. I told you what I think is interesting, but I really want to know, what do you think is interesting so I can address that? Okay, so let's talk about therapies. Right now, today, we have, I would argue, 3 or 4 potential therapies. And let me walk you through all of them, and let me talk to you about where the evidence is. And then let's talk about what's coming. So one therapy, that the only one that's gotten full approval by the Food and Drug Administration, the FDA, is Remdessevier. And Remdessevier is an antiviral drug. And the track record on Remdessevier for it being helpful on this is pretty mixed. There's some data that says it's helpful, some data says maybe not so much. And the takeaway on Remdessevier is it's probably not a slam dunk. It may be the kind of drug that if you give it super early in the disease course, it may help some people. So that's the only one that's gotten full FDA approval. Another one that has gotten emergency authorization is dexamethasone. Dexamethasone is a steroid. it is actually harmful if you get it early in the disease course, but it appears that if you get it late in the disease course, in more advanced disease, it can be extremely helpful. And the evidence there, the data there is actually quite good. And so I think it's been a major reason why death rates have come down, is because I think more and more people are getting dexamethasone, advanced disease, in the hospital. Good news about dexamethasone is cheap, widely available, and again, for severe disease, it's quite helpful and has contributed to lower mortality. Third is convalescent plasma. FDA gave emergency authorization of convalescent plasma. Basically, this is an old therapy that we've used in many infectious diseases. And basically what it is, taking plasma of people who've recovered from the disease and giving it, with the idea that that plasma is rich with antibodies against the virus. And the data on convalescent plasma is really mixed. And my best guess, this is a guess because I'm parsing through dozens of studies, is that convalescent plasma, when given very early in the disease course, first few days after infection, may be helpful, could be helpful. Later in the disease course, almost surely not helpful and maybe even harmful. And so convalescent plasma may play some role with disease modification and preventing people from getting super sick, but I don't know that it's a home run. And then last but not least so far is monoclonal antibodies. This is the one from Regeneron that the president got. There's one from Eli Lilly that Governor Chris Christie got. But the bottom line on antibodies is monoclonal antibodies. And by the way, for those of you who don't know, monoclonal antibodies are basically proteins that are designed to target the virus, and you give it as an infusion and it binds to the virus, and essentially your body then clears the virus. And most of the data I've seen so far makes me pretty optimistic that monoclonal antibodies will end up being helpful. Again, it's an infusion. You probably need it early in the disease course, and there's just not a lot that we know about it. The biggest issue with monoclonal antibodies is we just don't have that many doses. So even if it turns out to be a total home run, most Americans couldn't get it. We don't have that much of it. And this is frustrating because back in April and May, as these things were getting going, I and others advocated to the US government that they should just pay for production of millions of doses of these things. Even if they turn out not to be good, at worst, we'll have wasted a little bit of money. But if they turn out to be useful, we'll have enough doses for everybody. My sense is they're turning out to be useful and most people won't be able to get it because we won't have enough doses. So it's a missed opportunity. There is a lot of work being done to try to find therapies that can be given orally to somebody who's infected. So imagine you feel sick, you get a test, you're positive, you could take an oral course of something. Those are very, very hard to find with viruses. And while people are working on it, I shouldn't say I'm not optimistic, but I don't know that I've seen any data that makes me think, oh yeah, this is likely to work. So we'll see, but lots of experiments on that. And I would not be surprised if within 12 months, we see a lot more therapeutics that makes this disease much safer. But right now, there isn't much else on the horizon where the data is giving me much hope. But again, a lot could change. Let's talk vaccines. So vaccines, there are a couple of issues. I mean, one issue that was brought up was around vaccine hesitancy. So right now, it's true, surveys suggest that 40–50% of Americans say they wouldn't get a vaccine. Why are Americans feeling so hesitant? Well, there's always a small group of people who are very anti-vaccine, and we'd have to think about how to deal and how to engage them. And some of them we may never be able to engage, right? People who just believe that vaccines are some global conspiracy. But a lot of people are concerned because they feel like the vaccine process has been deeply politicized. And they worry about how quickly the vaccines have been developed. They worry about whether political interference has gotten involved. And what I say is, first and foremost, the scientific integrity of the vaccine development so far has been superb. All of the vaccines have gone through all of the rigorous steps that we expect from a vaccine development. And I have no reasons to doubt the integrity of the science here. I think where we got into trouble was when you started seeing things like the president saying, we'll make sure there's a vaccine before Election Day. People are like, well, how are you going to do that? That felt political. Then you had other politicians saying, well, I'm not going to take a vaccine if the president says it is going to be. And what I and other public health people have been saying is stop. Like, we don't want politicians talking about vaccines. This is not going to be a Donald Trump vaccine. This is not going to be a Joe Biden vaccine. This is going to be a vaccine created by scientists at the NIH, at these companies across the globe. These are global vaccine efforts. Science behind the vaccines coming from England and from Germany and from China and from America and Canada. And these are truly global efforts. And as long as we can keep the politics out of it, it will help a lot in building confidence in these products. We still then have to do the job of communicating to people. And what we see is very high levels of hesitancy in the African-American community, in the Latino community. And it isn't going to be folks like me just standing up and saying it's safe, please take it. We're going to have to engage with civic leaders and religious leaders and community leaders and political leaders in those communities. And they're going to have to become convinced that the science is good. And then if they are convinced that the science is good, then I think we're going to see that people take it up more. So I'm pretty optimistic that we will get to a good place, but it's going to take us some time. It's not going to be immediate and easy. Last thing is around duration of vaccines. So obviously we have no idea because we haven't gotten a vaccine out yet. So I'm going to get some speculation on how long I expect vaccines to last. I expect that most vaccines will offer 70–80% protection for 6 to 12 months. And if you push me today based on what I know, I would say I could easily imagine that vaccines give you that kind of protection for 12 months. Do I think the first generation of vaccines are going to give us 5 or 10-year protection? I'd be really surprised. So we'll have to study all of this stuff and watch all of this stuff. But my best guess is that in the first few years, we're all going to be having to get a COVID vaccine more than, about once a year. Could be more often than that, but I'd be surprised. My guess is once a year. But I can imagine a second or a third generation vaccine that might come out in a year or 2 years from now that could give you much longer protection. So we may get to a point where you get a COVID vaccine every 5 years, but that's not going to be likely in the beginning of this. The first vaccines that most of us will get, that I expect I'll get at some point in the spring when it's my turn, will be a vaccine that is maybe, let's say, effective for a year, and then we'll have to get annual shots.
So thank you. And I want to move to the next question, but as a segue into that, if you could speak a bit about just flu vaccines. So the question that I have next is, what's going to be the biggest obstacle for the coming winter months battling COVID and the possible twindemics of the flu and COVID simultaneously? And we know that we've never been successful in quite getting the flu vaccine where we need it, and it's always an annual vaccine. Can you explain why the flu vaccine has never been longer term or more successful, and then answer the question about the twindemics and what that'll mean this winter? Thank you.
Absolutely. So so let's talk about why you need an annual flu vaccine. It's not because protection wanes, though protection does wane a little. That's not the primary issue. The primary issue is that the strain of the influenza virus that's circulating changes every year. So influenza viruses have a lot of what's called antigenic drift, that the antigens on their surface change a lot from year to year. And so it's literally different strains of influenza circulating. And every year, what happens is we look at the strains that are starting to circulate in certain populations in Southeast China, in the Southern Hemisphere, and we make guesses. And we make guesses about which strains are going to hit the Northern Hemisphere during the winter months. And then we have to produce flu vaccines for those strains. And some years, those guesses are great, and we get 80% protection. And some years, those guesses are not so good, and we get a 10 or 20% protection. And that's just the way the influenza virus works. And there is a lot of effort to try to develop a flu vaccine that's what's called the universal flu vaccine that would work against all influenza viruses. It is technically very, very, very difficult because of the way influenza viruses are. Coronaviruses are very different than influenza viruses. Coronaviruses don't have that same level of antigenic drift. They don't kind of change around as much. The spike protein, which has been the target of most of these vaccine efforts, are pretty stable. And we think we can build a vaccine against it that is likely to work and likely to be effective. And that's why I think the coronavirus vaccine is relatively easier to develop. There are plenty of skeptics who point to the fact that we have coronaviruses do exist in humans and they cause the common cold. We've never developed a vaccine against the common cold. We think this virus is going to be different. And most of the data so far suggests that vaccines can be pretty effective, but we got to wait and we got to try. But I am hopeful that we will be able to develop long-term, vaccines that work. And then hopefully we'll find a way through either adjuvants or something about the way we develop the vaccine that gives us longer term immunity. Again, I'm not looking for lifelong immunity, but certainly I'm looking for at least 1 year, right? Because then if we all have to get a flu vaccine and a COVID vaccine every fall, that's fine. But what I'd like to get to is obviously vaccines that give us 3 or 5 or 10-year protections, but that's a long ways away. And I don't know that we'll ever get there.
And back to the
twindemic.
Twindemics and your thoughts about that. I mean, we do a lot of symptom attention at the university, daily symptom checks, and some of the flu symptoms are the same as COVID, some are distinguished, but just understanding what it is and then getting both viruses peaking during these months.
So I am hoping, and this is really about hope, that we end up having a really mild flu season. And the reason is that we know influenza viruses respond to the same what we call NPIs, non-pharmacologic interventions, social distancing, mask wearing, hand washing. All the stuff we're talking about for COVID also works for the flu largely. And so if people do a reasonably good job on those things, mask wearing, hand washing, social distancing, it'll make a big difference in influenza. And what we've seen so far is in the Southern Hemisphere, when they have their bad flu season during the summer months here, it was really, really mild flu, like down 80-90% compared to normal years. So far in the fall, we're early days, we're seeing very little influenza. Again, I'm not trying to be overly optimistic and say we will not be hit by the flu, but I am saying that if we do the things that we think matter for COVID, it will make a big difference with influenza. And if that happens, it will be one of the few silver linings in what has otherwise been a very tough year for all of us. So it just is more evidence that you've got to do those things like hand washing, mask wearing, social distancing.
Yeah. So our next question goes back to kind of your discussion of the 18 months. And question is, what was the worst federal failure in March, April, and May? Muddled messaging about masking, failure to initiate uniform test regimens, failure in support contact tracing, or something else?
It's a really good question. I would say the single biggest failure was a failure to take the virus seriously and communicate that effectively to the American people. I think if we had federal leadership in March that said, this is a very serious thing, it's going to be with us for 12, 18 months. We have a lot of work to do, but we're America, we can do hard things, and we can get going. That would have made an enormous difference because I think Americans would have been able to mentally prepare. Part of what's been hard is you keep hearing every other week, it's about to end, it's going to go away in April, the summer months will make it go away, we're rounding the corner. It's not helpful when we all know that's not true. Like everybody knows that's not true. So leveling with the American people, telling them the truth about how long we're going to be dealing with this. That's why I often begin with the 18-month time period. Not because I want to say at the end of 18 months, it's going to be all over. Still going to be dealing with it, but it'll be better, much better. So people need to know that, because then you can plan accordingly, right? So you're not like planning on, oh, in a month it's going to be over, and then we're going to have normal holidays. We're not going to have normal holidays. So I think that would have made an enormous difference. If we had done that, then that would have created the political space and the momentum to build up a great testing program. The fact is, we still don't have a great testing program in our country. We still can't get as much testing done as we need to. We should have ubiquitous testing by now. In May, we had the first authorization of an antigen test. What should have happened at that moment is the federal government should have sat down with the company and said, what do you need? How much money? And worked with other companies to create all the supply chains and the reagents. And we could have had millions and millions of tests every day happening around the country. That alone would have brought the pandemic largely under good control. We didn't. We should have had a whole production function around masks. Everybody can go and buy their masks on Etsy or Amazon. But the truth is, you don't know how about the quality of all of those. And some of them are really good and some of them are less so. And imagine that the federal government had invested resources. And these would have been tiny dollars compared to what we're paying out in other ways. So all of it, I think, is one failure after another, but it was predicated on an assumption that the virus was going to go away. And of course, everybody knew the virus wasn't going to go away. So there was a hope that somehow, if we didn't take it seriously, it wouldn't matter. It's mind-boggling that you could ever take that approach to an infectious agent to say, well, if we ignore it, it'll go away. It doesn't go away.
So here's a bit of a provocative question or provocative area, and I'm going to read this directly. Recently, 3 public health experts from Harvard, Stanford, and Oxford made the Great Barrington Declaration. The statement encourages governments to lift lockdown restrictions on young and healthy people while focusing protection measures on the elderly. Those supporting this assert that this would allow COVID-19 to spread in a population where it's less likely to be deadly, providing potential widespread immunity. What's your thoughts on that strategy?
Yeah, I've written a bit about this. It's one of those ideas that sounds really good until you think about it. And the moment you think about it, you realize it's completely unworkable. So let's talk about the Great Barrington Declaration. I know 2 of the 3 people who wrote it, and it's got a couple of problems. So the idea that we know young people are much less likely to get sick. We know older people get sick, and older people and people with chronic disease. So let's think about how this would actually work. And it's interesting because in a couple of follow-up stories that were written in major newspapers where they reached out to these 3 individuals and said, well, how would you actually implement this? They all said, well, we're not implementation people. We don't know how to implement it. Somebody else should figure that out. It's kind of like saying, I've decided tomorrow that I'm going to fly to Mars. And then you say, okay, well, how are you going to do that? I'm not an implementation person. Somebody else should figure it out, but I'm going to Mars. Like, no, you got to actually figure out how you're going to do that. You can't just say you're going to do something. So let's just think about the logic behind this. Sounds exactly right. Young people, healthy people, if they got infected, they wouldn't get super sick. Why not let them all get infected and protect vulnerable people? So first you got to figure out who's vulnerable. So what do we know based on the data? People over the age of 60 have much higher rates of complication. People with chronic diseases, high blood pressure, diabetes, other chronic diseases, obesity. So you say, okay, what proportion of adults are either obese, have high blood pressure, diabetes, or are over the age of 60? It's about 40 to 50% of adults. So you're like, wow, that's a pretty large proportion of people that you've got to put into a protected class. You got to protect half of adults. And then you got to let the virus run and get infections happening in the other half, or 60%. There are 2 problems with this. First is that we do know some young people do get super sick, and we don't know the long-term consequences of this. So I think people should be cautious about just saying that everybody who's young and otherwise healthy is going to be fine if they get infected. They may not die, but a lot of people end up having substantial chronic problems. But there's actually a bigger philosophical problem, not even philosophical, logistical problem. which is older people and people with chronic disease don't live on an island. You can't take 40 or 50% of American adults, put them on a boat and ship them off somewhere. They live in the same communities. So 25-year-olds live in the same communities as 45-year-olds and 65-year-olds. The single biggest predictor of outbreaks in nursing homes is the level of infection in the community. Because what happens is nursing homes, let's think about that, which is actually an enclosed community of older people. They need workers, right? They need doctors and nurses who don't live in the nursing home. They live in the community. And what typically happens is as a nursing home worker might go to the grocery store. And if the infection levels are high, may pick up the infection. Now they themselves might be fine. They're asymptomatic even. They come to work asymptomatic, and then they spread it to 30 people and 15 of them die. So there is no way, unless you can wall people off, unless you can take half of American adults and wall them off from the other half of American adults, this is not a workable idea. So it sounds fine on paper, but to me, it's so incredibly naive. And all the data says you can't possibly do this, that it really makes you think these three people, again, two of whom I know who are pretty smart, you think, what were they thinking? I think they were thinking this would be a good way to get some attention. I don't know any serious person who thinks you could possibly, like, what do you do with people who are 60? You just, and that's a lot of people, by the way, who are, or have high blood pressure. How do you protect them? What do you do? There's no obvious thing that anybody's figured out how to do this. By the way, one last point on this. Lots of countries have thought about this. Lots of countries have said, this is what we're going to be our strategy. Every country has abandoned it because they ultimately came to realize it is not workable.
Thank you. So this next question comes from an interview you did on NPR September 29th. That you said that the US COVID-19 situation was, quote, a public health failure. Can you speak to how the political environment, especially now, has influenced the public health workforce ability to respond to this pandemic?
Yeah, it is a public health failure. And you know, what's really interesting is that this is not the way our country has been in the past. When we think about public health interventions, like in the 70s, 1970s and 80s, we realized a lot of people were dying on the roads because people were drinking and driving, right? People would drink alcohol, they get behind the wheel, and they drive. And as you all know, that's a very dangerous thing to do. And so we passed laws and we started enforcing them, and we did educational campaigns. And there were a few people who were like, whoa, freedom. I should be able to drive while intoxicated. It's my freedom, it's my car, it's my body. Ultimately, those people did not get much political traction because most of us were like, you can drink all you want at home, but you can't get into behind the wheel of a car and into a public roadway because I need to be able to drive. And I need to know that people driving around me are not drunk. And so the common good that comes from those laws way outweigh somebody's freedom to go out and kill somebody. And these were not political. You didn't have Republicans and Democrats coming out on opposite sides of this. Seatbelts. There was a little bit of pushback on seatbelts initially, but pretty quickly we got to a point where we said, such an obvious public health thing to do. Even smoking and secondhand smoking, which for a little while was pretty political, ultimately people realized, like, you can smoke in your own home, but you don't have a right to smoke in public and give somebody else, expose somebody else. But so that has been a way that we've been able to make progress on public health in our country. It hasn't been perfect, it's been uneven at times, but it's largely worked. And the idea is, if you want to do something that only harms yourself, we wish you wouldn't do it. We'll work on trying to figure out how you not to do it, but you have a lot more freedom. But the moment you start doing things that harm other people, there's a problem. And public health interventions can be done. Mask wearing. When you wear a mask, when I wear a mask, I'm inside my office right now, there's no one here, but when I go outside, I'm gonna put on a mask. I may be protecting myself a little, but mostly I'm protecting other people. It's source control. It's like smoking. I can't walk into a retail shop, into a clothing store and light up a cigarette and say, hey, freedom, right? Like, they're gonna kick me out, and rightly so. And so that's the way we should have thought about masks. But what has happened is we've deeply politicized this, and mask wearing is somehow a political symbol. And there are people who believe that if you believe in freedom, you don't want to wear masks. And I think this is crazy talk. It's like, you know, you don't have a right to go and infect other people and kill them. And like, you just don't. And we make these kinds of decisions all the time in our society. And we have turned a lot of these issues into political issues, and they're totally unnecessary. And every single time that any of us, I mean, again, the scrutiny, I mean, the amount of like rage that I personally feel like I get, and every public health person who's been visible, I know gets from people who are so angry. And it's not because these people woke up one morning and decided they hated public health, but actually what's happening, and there are two sets of things that are happening, and I think people should know about both of them. One is basic misinformation. A lot of stuff circulating on Facebook, right? The kind of stuff like your Uncle Bill, I don't mean to pick on anybody's Uncle Bill, but you know, Uncle Bill shares some story of like some crazy thing. And we all know Uncle Bill, he shares crazy stories. There's that's just misinformation. That's just like junky information that gets out there. But there's something else going on, which is disinformation. And disinformation is literally campaigns, often really well funded by people and companies, and I don't want to pick on any specific ones, who are trying to change the narrative, who are trying to say that all the doctors and nurses in America are part of a conspiracy, and that stuff is much, much harder to counter. And what I think all of us need to do, and all of you in public health and otherwise, is become knowledgeable about what good information is, and then speak about it. So it's not, and so that you can be a force in countering misinformation and disinformation.
You know, a voice back. Lina, there have been some questions in the chat room. I've got many more, but do you want to pull a couple from the people that are on the call right now?
Yes, so Dr. Jar, there's a question about, so this pandemic has brought attention to the health disparity in our country, and where we are on addressing the health disparity related to the COVID-19 pandemic, and is it being seen globally as well? Your comments on that?
It's a fabulous question. So early in the pandemic, many of us said that COVID was going to be the great equalizer, that whether you were wealthy or poor, white or black or Latino or any other group, that we were all going to be affected. And while we have all been affected, this has been not only not the great equalizer, it has been the great kind of widening. It's been the source that has really widened disparities, has highlighted all of the problems in our society. It's been really the opposite of the great equalizer. And it makes us wonder why. What happened? Why did we get that part wrong, and why has it been so bad? There's a set of issues in the United States, and I can talk a bit more globally, but there's a set of issues in the United States that is longstanding, that falls along racial, ethnic lines, that this pandemic has really highlighted. And you hear terms like systemic racism, and so a lot of people are like, well, what is systemic racism? Systemic racism is many things, but many aspects. But for instance, we have had decades and decades of redlining. For those of you who don't know what redlining is a very simple idea, which is that if you're a middle-class Black person, you're going to be shown different houses. You're not going to be shown houses. You're going to have a hard time getting mortgages for houses in certain neighborhoods. It's another way of saying we've had policies, both explicit and implicit, that have pushed people into certain communities over others. And in those communities, you tend to see more dense housing. You often see more multi-generational housing. And so when the pandemic breaks and disease starts spreading, guess which communities get hit hardest? We think about essential workers. Who got called essential workers? Many of us could work from home. Many of us probably are working from home. Other people had to go outside, get on the subway or a bus, go to work, interact with people, even in the height of the pandemic when things were terrible. So what you saw was very different people getting infected, very different spread of disease patterns. And then in the early days, when the government was setting up testing infrastructure so people could test it, they didn't set those test centers up randomly or even in areas that were being hit hardest. They often got set up in kind of wealthier white suburban neighborhoods. And in the places where there were large outbreaks happening, there were no testing available. So you didn't know you would spread it further. The classic example of this was in cities, they would often set up drive-throughs. What if you didn't have a car? People would take buses to these places and they couldn't get tested because you had to be sitting in a car to get tested. No one sat down and said, I'm going to design a system that's biased against Blacks or Latinos or Native Americans. This is systemic racism at work. You design policies without thinking through the implications, and all of these other policies have landed you in a situation where there are these very disproportionate effects. So here we are, and this is the way this pandemic has played out. And what we need to do, of course, is try to rectify these issues in the short run. But as we emerge from this pandemic, we have to look at these broader issues much more deeply and ask, how can we continue to tolerate these kinds of policies that cause segregation, that cause disproportionately negative effects on communities of color, and how do we make sure that we don't do this again?
Thank you, Dr. Jha. So there's another question about testing. Do you have any insight why the pool testing is not adopted as a mass testing strategy?
Yeah. Oh, if I had $1 for every time I talked about, I think pool testing should be. So first of all, whoever's asking about pool testing, not everybody may know about pool testing. So let me tell you what it is, just so that if you don't know. Pool testing is the idea that you take samples from large numbers of people and you test the whole batch at once. So imagine that you want to test a university and you've got, I don't know, 5,000 students you want to test. You could run 5,000 tests, one on each person, or you could do pooling of even up to 100 people per sample. And every negative test, you've ruled out 100 people. Now, what if one of those 100 is positive? Then that whole batch will be positive. And then you can run individual tests on all those 100 people. But it's still far more efficient than doing it the other way. There's some data that pool testing may be a little less sensitive. They miss a few cases. And there's some technical challenges to doing it. As you might imagine, you got to take 100 samples and you got to make, but none of that is beyond capacity of organizations and testing sites to do it. So I have been a very big advocate of pool testing. I don't know, I've probably talked about it at like 100 times since May or June. And I continue to be frustrated that people have not been willing to do it despite its advantages. And so, again, I will acknowledge that there are challenges. I'm sorry, go ahead.
So I do need to tell you that our university, we are doing pooled testing.
Hey, great.
Asymptomatic testing of our students and our faculty and staff. And we've been doing pools of 12 saliva tests.
Wow.
It's been going very well. You know, these are asymptomatic testing on campus.
That's
so,
great.
Yeah, so there is one system that's using it, and that's UB and SUNY.
That's awesome.
So I have a question related to, and you alluded to some of this. We've had other experiences, but someone's very interested in the Spanish flu of 1918 and kind of compare the differences in things that were similar between these two pandemics and what lessons have we learned for the future. You know, I recall reading some information about the flu and that the basic public health, hand washing, distancing were some of the ways that the Spanish flu was dealt with. Again, back to your premise that those are in any one of these instances tried and true. But what is the difference between Spanish flu? We lost a lot more people. Obviously, we had less medical ways to help, but your thoughts on that? What lessons?
So much to say, so many interesting questions that come up with the, so first of all, I can't, this is the one downside of doing this as a Zoom. There are many downsides. I wish I could be there in person with you, but one of the downsides is I don't get to do like a little Q&A with the audience. But I was going to say, do you all know why it's called the Spanish flu? But many of you might, but let me just tell you, it's not called the Spanish flu because Spain is where the virus originated at all, or that Spain was where it was hit the hardest. It's called the Spanish flu because you have to remember the time when the virus was spreading. It was around World War I. It was in the middle of World War I, or at the tail end of World War I. And there were basically large censorship going on of newspapers around the world. One of the few countries that was not involved in Europe was Spain. So actually, Spain was one of the few countries that was reporting cases of influenza and people getting sick and dying because there wasn't as much censorship of Spanish newspapers because they weren't involved in World War I. And so the world largely knew about the pandemic. I mean, internally, of course, everybody knew it was happening. But globally, one of the few places that was really talking about it was Spain. And so poor Spain, they didn't censor their newspapers. And now everybody calls it the Spanish flu, but it didn't originate in Spain. They didn't cause the flu. Anyway, Spanish flu. All right, it was an influenza virus. And we think it killed between 30 and 50 million people around the world, a meaningfully higher number than this pandemic will. It also killed a different group. There were a lot of young people who died of this virus, and that was, of course, very tragic. The couple of the other kind of key points from this, there's so many things to talk about. Let me maybe just make a couple. The Spanish flu went in waves. You had a big wave in the spring, the summer was better, and then a much bigger wave in the fall. A lot of the same stuff we're talking about. There were fights about mask wearing. There was the anti-mask league of people who refused to wear masks because masks were an abridgment to their freedom. There were big questions about could you have schools open, and there were a lot of things that were happening outdoors, and a lot of schools happened outdoors. So many of the public health challenges that we are going through in this pandemic, those guys went through 100 years ago in our nation. The differences, of course, are we know the data much better now, and we track it much more live time, right? So I can tell you that we just crossed the 9 million mark in terms of number of people officially infected with the virus in the United States. That kind of tracking wasn't happening. There was no vaccine that was developed in short order. We will have a vaccine for this virus in the upcoming weeks and months. There were no therapeutics that were designed in the way that we've made progress on dexamethasone and antibodies. So there's a lot here that makes this meaningfully a better, well, we're much more advanced. We're also much more global, and that you'd think that would make things much worse here. And the virus probably has spread a bit faster here than it did, or faster this time around than it did in 1918. So summary, virus spread faster now, but because we have so much more technology, we're tracking it, we're developing better therapies, we're gonna have a vaccine faster, and all of that will contribute to far fewer people ultimately dying of this virus. Mortality rate, we think, may have been similar between that influenza, the pandemic influenza of 1918, and SARS-CoV-2, COVID-19 virus. They both have a mortality, infection fatality rate of probably about 0.8%, 0.9%, something in that range.
One question we've gotten is, this length of time where we're all kind of socially distancing. And for many people, it's very isolating, elderly that don't get to see, don't get to get out. And we have a lot of concerns about mental health issues, including in our own students. It's been very hard, I think, on them. We're a social, social society, and this distancing has been really difficult. What are your thoughts on the mental health issues, how to manage them, and danger of isolation, especially in young students, college-age students, and how to manage that until we can get past into a more or new normal life.
Yeah. I wish I had some good answers here. This is a very hard question. First, let me just acknowledge how important this question is. It is absolutely true. The mental health costs of this pandemic have been massive. And one of the many ways in which the mismanagement of this pandemic has led to this prolonged period of isolation. It isn't everywhere. If you look across East Asian countries, people are out and about. Much of their lives are not quite 100%, but 90% back to normal. Even in Europe, which is seeing a terrible wave now, had a 3 to 4 month time period where the virus level was so well suppressed that people did have a pretty normal summer, maybe too normal a summer. Mm-hmm. But the point is that when you manage the virus effectively, it does make it much, much easier to get out and do things. That's not happened here. We are social animals, and it's funny because on one hand, I mean, I'm just going to speak personally for a second. I'm like very publicly engaged. I'm doing this event. I mean, interacting with people all day. But actually, if you looked around where I'm in an office building where I'm maybe the only person in the building. I'm certainly the only person on the floor. I come in early, I leave late. I don't see any human in real life, just on TV. It's a very bizarre experience, and I'm fine. But for older people, again, college age students, incredibly difficult time. So I don't have any simple answers beyond try your best. So you can do two things. First, use technology as a way to connect with people, stay engaged with people, FaceTime, or do all the other stuff. Second is we can see each other. We shouldn't be locked down. We can see each other outside. Even on cold days, put on some warm clothes, go for a walk with a friend if you can. That's incredibly safe thing to do. Outside with a mask, walking, it's incredibly safe. To do those things, I understand it's not the same as sitting with a friend or being with a loved one. And I get it. I don't have any great answers, but there's a lot we can do. And I think we should not be fearful of doing those things that are pretty safe to do.
So the last is, I'm going to blend two questions that we got from our students. What got you personally interested in the field of global public health? And how can I be awesome like you when I grow up?
You shouldn't be like me. You should be like yourself. No, it actually gets to a slightly bigger point about careers and career advice that I often say to people. I have lots of students and junior faculty who come to me for career advice. And the biggest thing, and this is something for all of you to think about, you'll seek out advice lots of times in your life. Make sure the person who's giving you advice isn't telling you to be like them. Because we all know how to be ourselves. I can tell you how to do the things that land you in what I'm doing, but it's good for me. It's not, everybody else has to find their own path. But I do think that what's really important for career, and this will get to the first question of being interested in global public health, is you need to combine 2 or 3 things in order to be effective. One is you do have to care deeply about the topic. Because the days are long and some days are painful. And if you don't love the topic that you're working on, if you don't care about it and find it meaningful, it's hard to sustain it. It's really hard to sustain it. And, and again, I don't want to turn this too personal, and this is definitely not a woe is me. I feel like I'm incredibly privileged. But since the early days of March, it's been nonstop. Every morning, afternoon, evening, night. Doesn't slow down. It's just the pandemic hasn't slowed down. If I didn't care about this topic, I couldn't sustain it. And so part of it is you have to know what you care about. And I've cared about the topics and issues around global public health my whole life, right? Because it's about trying to improve the health and well-being of people around the world, and particularly people who are born into less privileged positions and have fewer opportunities than I do. But the second part, beyond caring about it, is you need skills. You need to bring something to the table beyond passion. Passion is a great start. It's not enough. And that's why you need training. You can train as a doctor. You can train as an epidemiologist. You can train as a public health person. There are lots of different things you can train in, but you need training. You need to show up with some set of skills, because otherwise you're just a well-intentioned person who can't do much. And that's not fun. And so if you want to be effective, get training and learn skills that are going to be valuable and impactful, and then go apply it in an area that you care about. And maybe the last thing is thinking about how to, one of the areas I think all of us in public health need to do better, and I've been working on my own myself, and I want to really make this a major part of what we do at Brown and other places, is public health people have to learn how to communicate more effectively to people outside of public health. One of the many failures in this pandemic is I don't think we in the public health community have always done as good of a job as we need to. And so if you're going to work on something, work on communication skills, work on becoming a more effective communicator of science and evidence and public health, because the country needs it and the world needs it. So it's an area that you can invest in.
So thank you for all the generous time on these questions. I have many more coming in, but I'm going to turn it back to Lina, who will close us out today.
Hi, everyone. I want to thank you, Dr. Jar, for such a great lecture and such an informative conversation. We love hearing your insight on those very critical issues that our nation and the whole world are facing. And we're so grateful for your generosity on your time with us today. And thank you so much. Before we end today's event, I would like to thank you, a few staff from Dean's office, Jennifer, Grace, Karen, Cindy, and Derek for your administrative assistant. And I want to thank you all for attending the 5th annual Richard Lee Lecture in Global Health. And we so appreciate you being here with us today. Thank you.
Thank you very much. This was a pleasure and an honor. I really